Oh, hello and good evening. Sorry, I was just typing. Welcome to Supporting Families. We have another episode coming to you live, and we are very excited for tonight's topic. My name is Chris Baier. I've been hosting this for a couple months, and it's really excited. Tonight's topic, I think one is going to resonate with a lot of you, whether you're watching live or even if you get it on the replay. It's treatment refusal and support and help for families, caregivers, loved ones, spouses, for those who are, having trouble getting into therapy and getting help with all sorts of mental health disorders. So very, very quickly, I just want to give a little bit of ground rules for everybody out there. Again, thank you for joining. Please use the chat for comments and any questions you have. This live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider, or you can contact a local clinician. If you need help looking for a therapist or special treatment, you can go to the IOCDF's resource directory, which is at iocdf.org/find-help. And that can kind of help you either find a local trained clinician or even somebody who might be offering teletherapy. The OCD Foundation is not a crisis hotline. So if you're in a crisis or you're ever feeling suicidal or unsafe, please call, if you're in the U.S., 988, which is the Suicide and Crisis Hotline, and you can do that by dialing 988 from your phone, or you can also access it by 988lifeline.org. You can also go to your local emergency room or call 911 if it is an emergency. And we want to create a safe space, so please be kind and respectful in the comments to everyone. It's a supportive environment. We're here with a community to help each other and learn from each other. And just a final note that this is being broadcast in several locations. It's being recorded, so just know that it will live on the internets for forever. So be conscious of that in any of your comments and questions. And I also want to thank Jack MHA for their support of this live stream. And thank you, Kim Vincenti, for the idea to start this. And one last reminder, we're looking forward to seeing everyone, if you're coming in live or attending virtually, the IOCDF conference in Orlando, Florida. Very exciting. So Dr. Alec Pollard, it's so nice to meet you. And thank you for joining us tonight. It's a really awesome topic that we have, and I wondered if we could just start quickly by, introducing yourself.
Okay. I always love introducing myself because it gets a little awkward. It's my pleasure to introduce me. It just doesn't sound right, does it? So I'm Alec Pollard. I am founding director of the Center for OCD and Anxiety-Related Disorders at St. Louis Behavioral Medicine Institute. I'm not done yet. And Professor Emeritus of Family and Community Medicine at St. Louis University School of Medicine. Now I'm done with that. Yeah.
You're also an author. You've presented at OCD conferences. I know you have a new book out, but there's been a few that you've written as well, correct?
Yes. Yeah. But believe it or not, none of them are strictly about OCD. They're about other things. And even this new book is largely about OCD, but it's really about it's beyond OCD. It includes other related disorders, anxiety, depression, etc.
So it's helping lots because, treatment refusal, doesn't just happen with OCD. I know that's a topic I'm most familiar with, but this live stream can actually give advice for a lot of others dealing with different anxiety and mental health issues. So thank you so much for being here. I guess let's maybe go into a little bit about the new book because it's the kickoff of tonight's topic. So it's titled "When a Loved One Won't Seek Mental Health Treatment: How to Promote Recovery and Reclaim Your Family's Well-Being." I know that it's kind of like a collaborative effort between yourself and some others. So what was like the inspiration for the book, and how has it been going? And are you planning to talk about it more at the conference and share kind of some of the tidbits of your findings and research?
Oh, I will for sure. I've been talking about the book for 20 years, and so I won't stop, especially now that it's published here May 1st. But if we go back 30 years in time, and I know what the audience is thinking. No way, he's too young. He must have been 15. And thank you all for thinking that. So we go back 30 years, and a group of us here in St. Louis, we're sharing our anecdotes about getting calls from families that would say, "Hey, my wife, my husband, my daughter, my son, my parent has OCD or hoarding or whatever, and they won't get help. What do we do?" And at the time, I had not seen the light yet. I was just thinking like all the other therapists out there, and I told them exactly what every other therapist tells them. I'm sorry, if he doesn't want help, there's nothing I can do. Have him call me if he changes his mind. Okay. Well, that was fine. And certainly it was good advice to say we can't treat him. Good decision to not try to treat somebody who doesn't want to be treated, even if they would come in. But it just didn't feel right. We were leaving these families in these untenable situations, and there was no one there to help them. And so really the book, the approach that we started doing and trying to help families, and then eventually the book, was all generated by selfish motivations. I was tired of feeling guilty about sending these families away. And so we started talking about, well, maybe we can help them, and maybe indirectly help the person that they're concerned about. And that person who has OCD or some other mental illness and just will not get help, or gets help but doesn't really get it. That person we came to call recovery avoiders. And I will, define that as a person whose behavior is incompatible with what you would be doing if you were trying to recover. So I want to make a couple of comments about this. First of all, it has to be a pattern of avoidance. It can't be just like one time, I don't want treatment. But more importantly, it's not meant to imply their intention is to avoid recovery. Nothing could be further from the truth. Nobody wants to be disabled. It's simply that the forces that are driving them to behave the way they do, and we can talk about that at some point, what makes people act that way, is the outcome of their behavior is recovery avoidance, meaning that it's not the intention, it's that the outcome of their behavior avoids recovery by engaging in those behaviors, even just the simple act of refusing to get treatment. So, at any rate, we invited families in. We told them in so many words, we're new to this, be patient with us, but we want to try to see if we can help you. And we're going to use what we know about behavioral change and family systems, and try to help you, and then maybe indirectly be able to affect the recovery avoider. And
so
yeah, go ahead.
Just a question. Would you if for first of all, I think the turn of phrase, instead of saying like you're resistant to treatment or something more negative, recovery avoidance feels like it's a bit more on a positive spin, or really kind of takes some of the blame aspect out of it, which I think is a nice reframing. But so you invited, you started by basically inviting these families in, saying, okay, if these are people looking for help, so let's start with them, and let's kind of like co-develop a system, and they can help us, and through us helping them figure out like systems that work.
Yeah, we weren't just shooting in the dark. I mean, we read, and we knew, we were cognitive behavioral therapists, so we knew about behavior change. It was more of a mind shift a way of thinking that we were questioning, like, why are we not helping the people who were the most motivated to change, which were these families, and they were suffering. And so why aren't we helping them? And that's what we're supposed to be doing. They're the victims of mental illness, even though we don't think about that. But families are often the neglected victims of mental illness. And so yeah, we studied, we saw what other people were doing. There wasn't much in the field of OCD, there were a few things that emerged later. We all know about family accommodations and things like that we needed to reverse. And there was a lot of research on substance use and families of substance use and interventions that had been tried there. So we started to put together a package, and then we applied for a grant from IOCDF, and they gave us a grant to study it and compare it to a placebo treatment. We did, and we found, for example, that we could successfully reduce accommodations without ever meeting with the patient, for example, just meeting with the family. But we could reduce the accommodations that the family was making, even though the quote identified patient was not in the sessions. And we did that significantly greater than the control group, who got more just education for the same amount of time that we did our intervention. But more than that, we learned what else we needed to add to the package. And we also realized that 5 sessions, which is the original package, was not enough for a lot of families. We were naive about that. And we even called it brief family consultation. That brief is not in the name anymore. Yeah, because sometimes it's months or even years, depending on the situation. It may not be weekly, but it just depends on the situation. Everybody's situation is different. So we started developing what now has become what we call the family well-being approach. And what characterizes it is really that we're concerned about the well-being of the entire family, not just the person with OCD.
So many of the things resonate with me, and that we found out, my family, as my daughter was going through treatment. Just like one of our things we realized, since it affected the whole family, our feeling was like if a whole family fights OCD together, the whole family can beat OCD together. And this, I work in a place that loves acronyms. So the FWBA, or Family Wellbeing Approach, is something that I truly appreciate from the acronym point of view, but also, like, what are the tenets of FWBA? I know that's like what you were able to kind of study and talk about in the book. So how does the family get started?
Yeah. So maybe we start with the assumptions. If the empirical foundations are grounded in, meaning the research is grounded in just good, strong behavioral research of behavior change, and family systems, how families interact and how they affect each other and how they can turn things for the better or turn things for the worse. Now, I want to be clear, in no way would I ever imply, and it just simply isn't true, that families cause mental illness. That's a ludicrous idea. But families can influence whether things go in the right direction or the wrong direction, based on how they interact with the person who's suffering from the mental illness. And our assumption is, our philosophical assumption comes down to the Serenity Prayer, which everybody in this audience probably has heard and is familiar with. And I can't quote it exactly, but it's, knowing the difference between the things you can control and the things you can't, and having the will to really focus on the things you can control and let go of the things you can't. And that's very abstract. And I promise we'll get into nitty gritty of this as we talk more. But that's sort of the general philosophy, because a lot of families are focusing on things they cannot control, like the recovery avoider, and not doing the things they can do to change. And there are reasons for that, how they interact with the recovery avoider. So we became more and more convinced over time that before we would teach ways to promote recovery behavior, we needed to help the families emotionally and psychologically, because they were beat up, and they were in no place to implement strategic strategies successfully without doing some of the things that we can talk about that we feel are not helpful to pushing somebody in the direction of recovery.
Yeah, it makes total sense. You want to, I mean, to get somebody in a place where they're ready for treatment, sometimes it does take those extra conversations, or to let them to hear what their issues are and understand the depths of the problem. And then, you can't just go in there and day one and be like, okay, we're going to run the marathon.
No, that's exactly right. And the analogy I use is to anybody out there, and there's probably a lot of parents out there who's a parent. Have you ever implemented a disciplinary tactic out of a moment of anger or frustration that you later regretted? And I think most of us say yes. When I grounded my son for eternity, that probably was a little bit harsh. And I don't want him in the house for eternity. I want him to get a job and support me. Come on. So why did that happen? Well, because I was doing things out of emotions. I was mad. And when we're mad, we're not thinking strategically. And so our approach is really trying to take the heat down in the family and teach the family strategic approaches that require some level-headedness. You can't be flying off a handle and do these things successfully. So that's sort of a general description of that. We can certainly get into the details of it.
Well, I relate to a lot of what you're saying. Resonates with me, just like as you learning in OCD therapy, that kind of like accepting the uncertainty of the things you can't control. The same and logic would apply, but no one's ever put it to me the way you have. But the logic would also apply to those who are involved in it, or in the family structure. You do have to accept the uncertainty. We used to say that, like, the future is tomorrow's problem. Because if a lot of the concerns I have initially was like, well, she's diagnosed with OCD. Oh my God, how's she going to get a job or go to college? And those were things that were so far in the future that really I didn't need to worry about it. And it was like, just accept the fact that that's not going to be, I don't have to worry about that, until later on. Let's deal with it here and now.
It's harder to deal with today's problems.
Yes, right. Let's get through those. I just want to take a second. Thank you, Nathan. Thank you, Grace. Thank you, Kim. And I know I might butcher this name, but Isa Tasia. Sorry if I bust you, from Mexico City. Sorry, it's raining there. Hope the sun comes out tomorrow. But thanks for the comment and the questions. It's great to hear where everybody's coming in from around the world, which is always good. We're always curious where people are coming from. I should say that I'm here, and it is Friday morning because I'm here in London, England. So good morning to you all from tomorrow, as you're enjoying your end of your day or middle of the day on Thursday. There's a question here about slightly off topic from what we were talking about, but it definitely related. It's like what can somebody do if a family might be making getting to treatment or recovery harder?
If what now? It's
like the family might be impeding the ability to find recovery or to get recovery.
Oh, okay. Well, it really depends on. Well, to be honest with you, it's actually more the norm that families in some way are impeding a person getting to recovery. And I don't mean that in a harsh or judgmental way at all, because families are just reacting. And this is our premise in the book, that families are doing what's natural to do. and they want to help a person who's disabled and to help them function or to reduce their anxiety or distress. And they want to encourage them to do better. And that might even include pushing them to go to treatment. But the problem is that when a person is involved in recovery avoidance, those two very helpful, normal, natural things to do devolve into things that are not helpful, like accommodating and what we call minimizing. And that's a term that we might want to spend some time defining a little bit, because it's probably a new term to a lot of folks. I'm assuming, because Chris, because I know you do a great job on this, and I've seen some of the other topics you've done, that most of your audience probably knows what accommodation is.
Oh, yeah.
Yeah.
Yeah, that was I think that's one that people are very familiar with. And one of the first things that I think I learned as a parent, like, oh, wait, I'm doing these things too. I can be feeding the issue. Yeah.
Right. Right. So would it be helpful if I can define, we've defined recovery avoidance, if I can define two more terms, and then that'll help us talk about things, if that's all right?
Yeah, absolutely.
Okay, so
education is a big part of like learning and how to keep changing up. And I think that's one of these things. You've got to keep learning about what's new and what's out there, and new terms and definitions. Super important for the audience and myself as well.
Well, we like to make up terms just to intimidate people, but hopefully they'll be useful too. So let's start with accommodation, because that's the one that most all of you know what that is. But we have a couple of new wrinkles in our definitions and subtypes that might be of interest to folks. So most of what you all think about probably when you think of accommodation is accommodations of commission, the things you do for that person to make life easier, to help them get out the door, wake them up, get their laundry done, whatever it is, get their homework done. Those are accommodations of commission. And by the way, if you go look for these terms in the internet, you won't find them except with us, because this is our concept. The accommodations of omission are the things we give up because of the things we're doing for the recovery avoider, or even if they're not a recovery avoider. That's those valued life activities. Like, I don't play golf anymore because it's too far, it's too many hours away from the house, or I've given up some of my social, I don't have people over, and we can't invite friends over because Johnny will think that they're contaminated and get all upset, whatever it is. So one of the things we discovered as we were working with families, that these are underestimated in terms of their importance and their impact on families' lives, including, by the way, some people give up work in order to be home.
Yeah, I can see that, especially to take care. You feel responsible, and what are you going to do? And there's that like love family connection. It makes sense. We always talk with the topics that we've talked about is like self-care, making sure you're making time for yourself. But these are things that we're basically saying, hey, this is the accommodation is omission. Yeah.
So that was an important discovery, because it's a big part. It's one whole step of our approach, which is getting back into those valued activities and starting to try to. And this is why I'm talking about the emphasis is on the things you can do for you, but also potentially indirectly for the recovery avoider. So the other distinction we make, let's leave that. I want to go to minimizing. Minimizing is the other family response that the reason we call it minimizing is the implicit message is, you can snap out of this if I just say the right thing, or lecture you for the 400th time, or get mad enough or frustrated. It's for those if there are clinicians out there, it's largely from the literature on expressed hostility in family research. But minimizing, we call it minimizing because you're trivializing powers that drive the OCD and or the recovery avoidance, the powerful forces, and by thinking you can just change them by saying something. And again, I want to be clear, these are all natural things to do and almost inevitable, because if you, and we have this diagram of how everybody's behavior is affecting everybody else and reinforcing it. So when Chris, if I had to accommodate you, and by the way, you're such a nice guy, I'd be happy to accommodate you, but only for a while, Chris.
That's right. Well, you don't want to I want to make sure that you're not having accommodation for omission. That's
right. I'm not gonna go out there and get you fish and chips at midnight every night. I just want you to know that while you're in London. But as I start to do it, I start to experience a burden. It's burdensome when we start doing these things we wouldn't otherwise have to do.
Yeah.
Then we start to get resentful and frustrated and overwhelmed. And when we do that, we start to minimize. So the cycle, if you could think about it, is we accommodate. That then reinforces, as everyone knows now, and this because of your great talks that you've had before, that reinforces OCD and recovery avoidance. So it takes, just to review for folks, it takes away an opportunity to practice recovery behavior, and it takes away the motivation they would have to go get help, because we don't go get help unless we're miserable. Nobody goes to see the doctor to be a better person. Well, okay, maybe some people in California, but other than that, nobody does that. They go when they're hurting. And so that's why when we accommodate, we're reducing their distress, which is the very thing they need to motivate themselves to go get help and also to work hard in getting help. All right, so that's accommodation. Now, that's the effect on the recovery avoider. Now it also affects us, and now we're minimizing, we're getting cranky. Maybe I'm trying to be diplomatic.
Okay. Yeah, there's a lot of things that you say that you regret talking about, like going back to grounding somebody for eternity.
That's right.
A lot of things that you just say, and and you feel, and like I, as a parent, have said things that I feel like super embarrassed about later on. Like, I can't believe I said that. I can't believe I blew up on her. I can't believe I screamed in that. Yeah,
absolutely.
I do. I lost my patience.
Yes, and you know why you do that? Because you are human.
That's true. Yes.
Shame on you, Chris.
I know, for having an emotional response.
Yeah. So we really try to help the families understand, because some of them feel guilty about what they've done, or like you say, you feel later ashamed. We try to reduce that as much as possible, because everybody's just being human. You're doing what instinctually you know to do. You just don't realize the outcome eventually is going to get you into what we call the family trap, and that everyone is trapped. The more you accommodate, the more they avoid recovery, or the more their OCD gets worse. And also the more you get burdened, the more you minimize. And we got to the final piece of the trap now, because that minimizing also makes recovery avoidance worse, because the person does not trust. It raises anxiety because you don't get it. You think I can just stop this because you're yelling at me. Now I don't trust you. I don't. And so you see people avoiding the family and hiding in the room and doing, and so that whole cycle, so that anxiety. So what is raising anxiety and having to defend your behavior do? It makes your OCD worse and your recovery avoidance worse. So that's the cycle. We have nice little graphs in the book, but it's easier to see, but I'm trying to describe it as best I can verbally.
Yeah, it makes sense. And I feel like, a lot of the work that you have to start doing with families is kind of unwinding and like figuring out the extent of the accommodations and the minimizations, and like how much everybody's part of it. And so just like therapy takes a while, and there's 2 steps forward and 5 steps back. Sometimes you have to do that with like the spouse or the loved one or the sibling who's ever there. Do you actually, a little tangent, but do you, when you say you bring in the family, is it one person, or you're bringing in everybody at once, or just the family members and the one without, who might not be seeking treatment? So you're treating as a group, or
the person with OCD, and we're just saying OCD because that's our topic tonight. Yeah. But it could be the person with social anxiety, the severe social anxiety disorder, or depression, or whatever, agoraphobia. But if just so everyone knows, when we say OCD, we mean whoever the person is with the mental illness that is avoiding recovery in some way or another. So we don't have that person in. It's we don't allow them in, and that might sound kind of funny. What? The person with OCD doesn't get to come. They're a recovery avoider. They're not going to do anything constructive. If they were, the better thing to go straight to treatment. Yeah. And then you work with the patient's therapist. The family doesn't need to talk to us. They should be talking to the therapist of their child or their husband or wife or whatever. And then we will see anyone in the family who's on board. But we won't allow anyone to come to sabotage. If they're not on board, we tell them to stay home. And so I'm just thinking about the families I see now. Sometimes it's one person. Very commonly 2 people, especially if it's married. If they're married, or a couple that has a child, they're talking about their child. So, but sometimes I've got grandma, grandpa, aunt, uncle, all
everybody's on there.
Yeah. If they're all on board and they are involved, especially if they're involved in the accommodating, the reassurance providing, the whatever it is, it's better if they're involved, unless they're not on the same page.
Yeah. Let's play. Let's play a little. You might know if you've been accommodating and minimizing too much. If, like, how, for those out there who might be like, do I fit into this category? Maybe, because I think sometimes you focus so much on I need to get the person has the mental health disorder, OCD. I need to get them help, and that's where I want to put my focus versus like, oh wait, maybe I need to if they're not going to take care of themselves, I need to take care of myself. And so putting yourself first, how might somebody go, hey, maybe, this family treatment might be what I need.
What you mean? What are some of the signs of it?
Yeah. Things somebody, hey, maybe so that I'd love to get people thinking that, hey, this is like, it's okay to do. And what are some things that, behaviors that you might be having to go, hey, wait a minute, maybe it's time for me to start unwinding.
Well, in chapter 4, by the way, Chris, you'll appreciate that chapter 4 talks about the obstacles that you will run into if you try to change things that happen in the family, and obstacles from the recovery avoider, obstacles from other family members, but also obstacles from yourself. And some of those have to do with misguided beliefs about responsibility, self-care, selfishness, beliefs that promote people being stuck. So, for example, I can't take care of myself when I need to be taking care of my loved one with OCD. Which is completely the opposite of what is true. There's a reason why flight attendants tell you to put your oxygen mask on first before you help your child.
Yeah.
Because if you're not in any state to help them, you're not really being helpful. And so
you have to breathe first.
Exactly. And the better shape you're in. Yeah. And I want to add a second reason for this, for those who might be maybe reluctant. One is your mental health is important for three reasons. One is you're a human being. You deserve it. Why is it just the person with OCD's mental health that we care about? You deserve well-being. Okay, that's number one. Secondly, you're going to help that recovery avoider better if you're in better shape, if you're not angry and frustrated and is guilt-ridden. And finally, when you help yourself, guess what? You are being a role model for your family member, because if they're a recovery avoider, they're not taking responsibility for their life. They're not looking honestly at their problem and taking inventory. If they're a recovery avoider, I'm not saying everybody with OCD is, by far not. But if they are, then what are you doing when you take responsibility for your life and your behavior, look at the things you can change and work hard to do that? You're being a model for that person. So for all those reasons, it's really important. And I know, Chris, you probably, I'm singing to the choir, especially for you. I mean, when you guys said you talked about self-care and self-compassion and how important that is. But
Yeah,
I would
there were things about putting up boundaries for ourselves and just natural things that we just stumble upon and saying like, hey, well, we have another younger sibling. She needs time too, space. So, okay, OCD is not going to get involved when we have time with the younger child. So things that we had to learn the hard way. You've put years in and through your, all the years of practice and treatment, now have a way to help other families kind of do that with the system.
Yeah. Yeah. And so the main thing, this family well-being approach, it's not so much like what disorder it is or anything like that. We found that the families who are most appropriate for it have like a certain number of characteristics. One is they have somebody in their family that has OCD or another mental illness. Second, that person is a recovery avoider. And that means that they either refuse treatment outright, or they may even deny they have a problem. They might say they have a problem, but it's not psychiatric, it's a quirk. They may admit it's psychiatric, but think they can handle it themselves. They may even say, I need treatment, but they're going to all the wrong treatments. They're looking at the latest fad or whatever, supplements, but they're not getting the evidence-based treatments that are there for their condition. And finally, they may go to treatments at the insistence of others, but they never seem to benefit from it. And
that can be hard. Yeah.
Yeah, you can be in treatment and be avoiding recovery. So those are all different examples of that. So if you have that person in your family and you are affected emotionally by their disability, and you tried everything you can to change things and it hasn't worked, and finally you're open to trying something different, that would be a family that would be a good candidate.
Ready for, a good candidate for treatment and have some positive results for themselves and their own mental health, which is, as we talked about a few minutes ago, so important. By the way, I just want to thank everyone for joining us. Some of the comments in the chat, which is great. We're talking to Dr. Alec Pollard. Really, the topic tonight is kind of refusal of treatment for all sorts of mental health disorders, OCD being the focus, but just, ways to help those who are families, caregivers, extended family, loved ones. His new book, When a Loved One Won't Seek Mental Health Treatment, How to Promote Recovery and Reclaim Your Family's Well-Being, is kind of out now. I guess you can grab, I'm sure it's Amazon and wherever awesome books are sold.
Yeah, actually, I'm right after this, I'll be out on the street selling it to strangers. You're walking by. If anybody happens to be on my street, come on over. We'll sell it.
I actually, will it be in the are you going to be signing copies or anything at the conference next month, or I don't know if we still have the bookstore and stuff?
Yeah, I'm pretty
Oh, that's
sure.
great.
I thought they were going to. No, I'm not sure but if there is a book signing thing, we'll do one. Yeah, we'll do it.
That's fantastic.
Yeah, and I'm now. It's kind of ironic that for the last several years, I've talked on this subject directly to families at the conference, and this is like the first year I haven't done it in a while. But there are two. One in particular, panel discussions that I'll be on, where we will be talking about this.
Oh, that's fantastic. Can we take a second and just shout those out so that folks who are going can jot it down and know what's going on? I know you can also check the IOCDF website and find the schedule, but
no, we can't, because I don't know I don't remember.
Just look for your name. Yeah. See,
like,
the name's on the screen. You can just go to the IOCDF OCD conference website, and then you can search for speakers, and then you'll be able to find the times and the days and hear this in person.
One, if not both, there's I think I'm on 3 different things, but one is just my colleague here and I are talking, kind of going through the different treatment options and how to make decisions, and not necessarily related to families, but just like inpatient versus outpatient versus residential versus IOP, and then also other choices you have to make in terms of treatment, medication, ERP, whatever it is. So we're just it's kind of a basics of going through it. That one we'll probably mention the family stuff, but the other 2 are, I think they have family in the title of the talk, so it should be pretty clear.
Yeah, well, and I will definitely look forward to seeing you next month. We do have a couple questions from the chat. Let's get to that. First question, Simon or Simone, thanks so much for the question. So for a loved one that's refused or maybe stopped ERP treatment, could a family member recommend an alternate evidence-based treatment or to get the loved one started? So maybe a way to encourage something different or get them to try something different if they say, oh, ERP doesn't work for me.
Well, there's a limited number of alternate, yes, in theory, but there's a limited number of evidence. When you say evidence-based, there are some newer approaches like inference-based CBT that is not quite have the level of evidence. I think that the foundation needs to call it evidence-based, but it has some promise. And there's some, and I think trying something, even if you don't have the research, rather than not doing anything, is much better. But you certainly want to evaluate what evidence is there before you go forward. But and then there's cognitive therapies and ACT, something called ACT, that are not classically called ERP. They have exposure and response revenge wrapped into the approach. They may not call it that, and those are promising. They may have a different spin on it than a classical ERP therapist might have, but it's, I find it's kind of hard to walk through the door without touching a doorknob. At some point, exposure's kind of necessary.
Yeah, you're gonna need to do
what you call the treatment. But I would say this, that, and I think this speaks to a couple of other options and one of my other interests, which is treatment interfering behavior. So some people,
TIBs, right?
TIBs, yeah,
TIBs.
Call them. They sound cuter if you say TIBs. But
TIBs.
Yeah, so that does not have enough attention among clinicians. I will say that. And I think it's a reasonable thing to consider, see if you can find a clinician that will work with sit with them and not just run into ERP, but sit and try to figure out, why has that not worked for you? There's a limited number of possibilities, and then try to address that reason. If I get somebody who comes to me and has been to, other clinics, 5 other clinics, 1 other clinic that knows what they're doing, and that's important, and I know they know what they're doing, I don't even start talking about ERP. I want to figure out what happened. Why didn't it work? And I would say if I can't give you a reason or something I'm going to do different than what you've done before, you shouldn't come to me. So it's not just keep banging away at ERP. There's something that is getting in the way most of the time of the individual truly engaging.
And,
Showing
and
up
to
for
that too,
sessions is
yeah.
not engagement. It's what you do between sessions. It's the most important thing. And if you're not doing your homework, you got to figure out why and how to help you do that, because that's the reason. It's not that ERP isn't working. I think about think about a medicine metaphor. If you just put the medicine in your mouth and you swish it around and spit it out, it's not going to help you. And that's what some people do with therapy. They don't really put it in their mouth and spit it out, but you know what I mean.
Well, you're with your patients an hour, 45 minutes, 2 hour, very short time in the consideration of how many hours there are in a week. So much of the, the onus and the responsibility is on that person to say, okay, you gotta step up and do the work. And that, I know it's easy for me to say and harder to do, but there's a skill learned behavior and an understanding that has to happen in order to go, hey,
absolutely,
okay, I do this.
And I do want to say, Chris, to that person who asked that question, I want to add one more thing. Suggest anything you want. Give them information. It's not going to hurt as long as you do it once. Okay.
No, that makes sense. I think
knows what I'm talking about. That once is offering a suggestion. 2 or more times is nagging. And that's what we call minimizing in our book, that you're now making them more defensive, getting anxious. So you gotta be careful that it's you're laying out ideas and then you back off. Don't tell them 14 reasons why they ought to do it.
Something you mentioned, it doesn't necessarily answer this question, but something I think that was something I learned and something that will stay with me is kind of like role modeling that behavior. So by watching somebody else going to the loved one going to therapy and helping themselves, you might get the courage or the interest to try the treatment again, or to work with your therapist in a different approach, or I know that a lot of times people want that quick fix, but it does something that it does take time to get there. One question I had for you, and this does relate to maybe the frustrations that some loved ones feels like, this person might be living in their house. They might, they need their care, or they've taken on this extra role of caregiver. I'm talking more about like parents of adult kids, or maybe your spouse has OCD. So, there's, it's not like you can get the person. How do you set boundaries? How can you help that person kind of start to, get a little bit more control of their own life and let OCD, step back a bit?
Yeah. So what most of the stress that's in families, and let's just take the situation where the recovery avoider is living with the rest of the family in the house. By the way, it can be stressful even when they're not. There is a telephone, and that can become a focus of reassurance seeking and all sorts of things. But let's take that situation where they're living in the house. Most of the conflict and fights that occur, not all of it, but a good portion of it, is because we're trying to get them to change. And that causes a fight. Our focus in the beginning, while we're trying to bring the heat down in the family, is on yourself, the family member, and not trying to, all right, he's sleeping all day. So what? You got a long life ahead of you. You can deal with it later. But if you try to get him out of bed, you're going to be in a fight. You're going to be And so a lot of the fights are because we're trying to get them to change now, today, instead of taking care of ourselves. So there's a period of time where the best thing you can do is back off fights you don't have to have, and save your fights for things where their problem is directly interfering with your life. That's different. So, if somebody is in the other room doing rituals for 2 hours, leave them alone, unless the therapist has asked you to do something. But if they're standing in front of the television, you can't see it while they're doing the ritual. That's different. You have to address that in some way. So the first thing is to limit the conflicts that you have some control over to those things that directly interfere with your life. And that's where our approach starts. Is we start with the accommodations that are the most burdensome and directly interfere with their quality of life.
With their being the loved one or the family member. Yeah.
The family members, yeah.
Yeah, that makes sense. The first issue that we started to tackle with my daughter was the issue that affected us most, which was sleep. She had a really hard time getting to sleep, which affected our lives. So it was like, that's what we're going to start with.
That's a good example.
Inadvertently, but yeah, it was just something that we found by accident, but it made sense.
Just to use that example, Chris, because that's a common one, because like a lot of times people who have adulting challenges, we'll call it, who are late teens or adults living at home, they often stay up all night. Now, if they're making a bunch of noise that's keeping you up, that's different. But if it's the parent says, well, it just bothers me that they're up on it. No, that one you got to let go of.
Yeah, that's on you. Yeah,
that's right. But if they're interfering with your sleep, then yes. And you limit in the beginning things to those kinds of stresses. Also, to be honest with you, you're going to get less objection usually from the recovery avoider for things like that. I mean, that they can see, yeah, I'm waking you up when I cook at 3 a.m. and buying pots and pans in the kitchen. Yeah.
And I think one of the things that I feel like the plan is talking about, the suggestion of like, pick your battles, or make, if it's not really bothering the work or the life that you're leading, then why make it a fight? Why make it an argument just because it frustrates you? Those are things that you deal with over time. And there might be a time when through therapy, you're saying, okay, now we're going to address that. But it's like kind of a part of unwinding the spiral that you're in, or the web OCD has brought you in. Allows us to say, like, let's focus on let's maybe make the issue smaller. Let's concentrate on the things that really bother you, and then we'll worry about the other things later. Yeah.
Yes.
Okay, I understood that. That's great. Question from the audience. So someone who's accommodating, where do they begin? So, their child is, their rituals, hand washing, et cetera, is kind of like controlling their lives. So the question really more is how to make it stop. But I think the more important thing that Cheryl added was, where do we begin?
Well, if you mean where do you as a family member begin to change your behavior, just to be clear. So you look at all the ways that you are accommodating, and then you put a plan together, and you don't stop everything. I mean, I know probably everybody knows this, but let me just state the obvious. You don't stop everything at once. And not just because it would be painful for the OCD sufferer, but because it'd be painful for you, probably, and you probably won't follow through. So that's another thing that we emphasize a lot. We'd rather you do something less ambitious, but really do it, rather than get all ambitious and not do it. And a lot of times when we do those ambitious proclamations, well, I'm going to stop, blah, blah, blah. It's because we're upset, and we don't not thinking about, am I really going to be able to follow through with that? So look at the things that you really can stop doing, and the things you have control over. And usually people are going to prioritize the things that bother them the most or the most interfering, um, and start with one thing at a time, and then add another one. By the way, the other thing that we really emphasize, um, you don't do this impulsively in the moment. You plan it, you strategize it, and you write it out for the recovery avoider. I want to change how we interact. I want to treat you better, and I want to treat me better. But the only way that I can take care of myself is to stop doing some of the things I'm doing for you, or at least in the way I'm doing it. And because there's two reasons I want to do that. I want to do it because I want to feel better. And I also realize that when I do these things and I get burned out, I don't treat you well. And I don't want to do that anymore. So I want to treat you better. I want to treat me better. And here's my plan. The first one I'm going to do is next week. And I'm going to, when the problem when sometimes happens when we're going out to dinner and you're stuck in your room doing rituals and the rest of the family's waiting and you're getting more pressured. And then we go up and try to help you. And then we get mad. And then we go to dinner and we're all mad and we're late, or we don't go to dinner. We're not going to do that anymore. We'll tell you what time we're leaving, give you a heads up. If you're not ready, it's okay. We're not going to yell at you. We're not going to be mad. We're just going to go ahead and leave. We'll bring you some takeout if you want it. But what we're not going to do is get in that fight. That's just one example.
Yeah, I think setting that conversation, and then the kind of being aware. So you said you don't start from day one, but having that you're bringing up something else that like we did too, which was to say 2 weeks before we started really trying to cramp down on ERP, and we're going to start with this. Remember, next week, we're going to do exactly what you said. Remember, this next week, we're only going to stay in bed with you for 5 minutes, and we're going to leave the room for 10 seconds and then come back. Remember that? That's right. And so it's not a surprise and you're not aware. And then setting up some of those things, I think somewhat planning too, like we're going out. This is what we're going to do. If you're not able to join us or something happens, this is what, well, just so you know, we're going to move forward and go to the event, or, we're still going to go to the store. Super important. So we are almost at time. This has been a fantastic discussion. There's a lot of comments and positive sentiments about the topic tonight. I don't know if you've seen them. There's been a thankful folks out there listening that we're talking about it for a lot of the adult audience. So it's really great.
I haven't seen any comments. There's probably something comparable to chat, like on Zoom or something. I don't see it.
So it's StreamYard has this kind of like panel on the right where you can see the comments. But anyway, there's a lot of appreciation for the work that you're doing, the advice you're giving, and there is a lot more out there from Dr. Pollard, not only in the book but also some videos online. So a good name to research. So folks can find the book on Amazon. That's out there, and then you see the name on screen. You can search that, or bookstores, and potentially at the OCD conference next month, where maybe you can get a signed copy. Where else can folks?
If you come to the meeting, I'll sign your copy.
Where else might be able people find you or your facility on social media or on the web?
Well, there's webinars running around and podcasts and things. Probably going to be doing a bunch of them because the books come out. So there'll be future things. Some for professionals. We're trying to train more professionals to work with families with this particular approach. But the book is really written directly to families. We started to write it for therapists to help families, and we thought we're going to do better if we go right to the families. And I'm glad we made that decision.
Yeah, it just comes to someone from the IOCDF might be able to put a link in the chat. That way, if folks want to kind of read more about it, that would be really helpful. And as a reminder, the film OCD Kids Movie. You can watch anytime at ocdkidsmovie.com and follow stuff on socials at OCD Kids Movie. I just want to close this out with a little bit of some closing announcements. Remember, the IOCDF is a donor-supported nonprofit. So if you enjoyed this conversation or others that the IOCDF has, and there are many throughout the week, you can donate at iocdf.org/donate. Anything is appreciated, and all of this work is that they do behind the scenes, and the fantastic volunteers and those that work at the IOCDF, all donation supported. So thank you so much if you're able. And we hope to see you next month at the 29th annual OCD conference. It's going to be in Orlando, Florida. This is a great opportunity to not only learn from experts, therapists like Dr. Pollard, but also meet lots of families and loved ones going through same. It's a huge community event. I think that's the thing we've learned the most is just learning that there are so many others out there that are going through the same thing. So if you're interested, you can register at iocdf.org/OCDcon. Also, usually the hashtag of the event is OCDcon. And you can, if you're watching on YouTube, don't forget to subscribe, and you can follow the IOCDF on all the socials: Facebook, Instagram, X, Threads, TikTok. They're on them all. We thank you, Dr. Pollard, for this great conversation, and we'll be back next month with another Supporting Families. Thank you all, and have a great evening. Oh, that was fun.
All right.